Good evening, everyone. First of all, I would thank the organizers and Dr. Amit for inviting me to deliver this topic. So as we are aware about the liquid biopsy, AI, probably my role would be very limited. But coming on to the present era and today, the image guided biopsy sampling is must for all the things. So first of all, role of tissue sampling, why it is important? It is important first to prove that it is malignant lesion, for guiding, for staging, and for treatment, planning the treatment. So what are the types of biopsies that are available in the present era? So first is a surgical biopsy where the surgeon will open it and then take a biopsy. Another is endobronchial lesions, that is via bronchoscopy guided and EBUS guided biopsies. And third is a percutaneous biopsy, that is image guided biopsy. And why image guided biopsies are important? Because they are more precise. We can target particularly the metabolically active area, and thus it can repeat less, so there is less incidence of repeat sampling, and it is safe because we do directly it under the vision. Whenever we see vessel, we go either above the vessel or below the vessel, and thus are minimized. So imaging modalities are ultrasound or EBUS guided biopsy, fluoroscopy guided biopsy, CT scan guided biopsy. So these are images of ultrasound guided biopsy where if we see a lymph node in the neck region, then definitely it is ultrasound guided biopsy. When it is a mediastinal lymph node close to the vessel, then it is EBUS guided biopsy, and fluoroscopy guided biopsy when we are suspecting metastatic disease. So this is a cervical region biopsy where the biopsy is done under fluoroscopy, and CT fluoroscopy so as to reduce or minimize the radiation to the patient. And last is a fusion, that is a PET CT guided biopsy where we combine a CT scan and a PET scan and then do a guided biopsy. So image guided, what is the significance? Because it has a high diagnostic accuracy, high sensitivity, specificity. Biopsy range, image guided biopsy ranges from 82 to 99%, and specificity is around 86 to 99%, and accuracy is around 97%. So for diagnosing malignancy, so when is high sensitivity and specificity, obviously what are the indications of the biopsy? So indication of biopsy are whenever there is a new or enlarging solitary nodule or a mass, or whenever there are multiple nodules which are evolving when the patient is on the chemotherapy or after radiation. In a known case of malignancy, hilar mass to prove whether it is malignant or benign, focal infiltrates whether it is actually disease or it is an infection in already known case of malignancy. And in cancer, in lung cancer, where there is personalized era, personalized chemotherapy can be given. Further, what we and molecular markers of these lesions. Coming on to the contraindication, actually there is very limited contraindications for doing a biopsy. Obviously uncooperative patient, we can do it under general anesthesia. When there is positive pressure ventilation, severe respiratory distress, pulmonary arterial hypertension, and severe interstitial lung disease. So these are some of the minor contraindication or a relative contraindication. So coming on to the pre-procedure workup, what do we require is coagulation parameters less than 1.5 and CBC that is more than hemoglobin more than 8 grams per deciliter, and of more than 50,000. And potentially patient needs to counsel regarding the complications where if patient is outpatient, then he needs to so whether he is flying back on which day, all needs to be taken into consideration. And if patient is on anticoagulation, needs to stop anticoagulants. So does every lesion requires a needling or a biopsy? The answer to this question is when you do not have a contrast scan, it's just a plain scan, we see a mass lesion in the left upper lobe, and when you do a contrast, there is a pseudo arising from the internal mammary vessels, and then this can be easily coiled via interventional approach, and then coiling is done. And thus, so coming on to another thing, what positioning of the patient do we require while doing a biopsy? So whenever the lesion is located anteriorly, obviously your choice would be anterior approach. So size of the lesion, yes, anything above 8 millimeters needs to undergo biopsy. Patient needs to tolerate, patient needs to understand which positioning is there and needs to be there in at least for 30 minutes before, because the ribs posteriorly, ribs moves less than the anterior ribs, and it decreases the anxiety of the patient. So these are the 4 different scenarios. So this is a mass which is predominantly located posteriorly, where we do biopsy in a prone approach or posterior approach, or this can be even targeted via ultrasound guided, because there is a effusion with it, so that this can be easily seen on ultrasound. You can even we can even do biopsy in a supine approach, because the lesion is anteriorly located. The large lesion and the small lesion, and as small as 7 millimeters, can be targeted. So while targeting the biopsy, what do we need to target? It is actually the solid enhancing component which needs to be targeted. So or a subpleural location where we can go in a longer approach. So these are 3 different clinical scenarios where the mass is located on the lateral side. So we need to see the bronchus cut off. Even here there is an endobronchial lesion, and always we need to target the central component, which would be less enhancing as compared to the collapsed lung, which would be more enhancing. So this needs to be targeted always, and here patient is already on chemotherapy, nodularity or irregularity along the cystic area, and there is some solid. So all these things need to be taken into consideration while doing a biopsy, and this is how all 3 patients turned out to be positive for malignancy. And thus the targeting of the right lesion is helpful. And where do we need a PET CT guidance? So whenever there is a small nodule or small lesion which can be easily detected on CT scan, that is a time when the biopsy needs to be done. Either an anterior approach, anterolateral through a collapsed lung, or a posterior approach needs to be done. And there are whenever there is a cystic lesion along that, there is solid enhancing nodule, that is the time when these biopsies are pretty much helpful, because we need to target those areas rather than from the cystic area. So some of the basic concept, like a free breathing motion, one needs to take care about the internal mammary vessels which lie close to sternum. We need to go as parasternal as possible or transsternal while doing a mediastinum or the lung biopsy. Avoid traversing the fissures. We need not go through and through, and avoid the fissures, and always go above the rib surface, above the surface rather than from the under surface, because intercostal vessels go below the rib surface. So this is like always below the rib surface. Intercostal vessels are seen below the rib surface. So your trajectory should be always above the rib surface. So fissures need to be avoided. Anterior lesions via anterior approach, posterior lesions via posterior approach, and that is the correct way of doing the biopsy, so that pneumothorax can be avoided. Another is a free breathing movement. So whenever patient is having a heavy breath while doing a biopsy, and if the lesion is moving up, your trajectory needs to go cranially, that is the fulcrum of the needle needs to go caudally, so that the tip of the needle points anteriorly, and if the lesion is going down, your tip, the fulcrum of the needle goes cranially, and then the tip of the needle goes caudally. So it's inversely related. So it depends, like if you do more biopsies, you get accustomed to this free breathing motion. Many times when there are smaller lesions, we target tangentially or oblique approach while doing a biopsy. So many times tangential is much better in small lesions, because the chances of pneumothorax is avoided. Emphysematous changes needs to be avoided, because the chances of pneumothorax increases, and thus the indwelling catheter time decreases. So basically the technique is pretty simple: low kV MA technique. local anesthesia needs to be given, coaxial technique with single pleural puncture, and need to have a coaxial system and take multiple course into it. So post biopsy care, only the imaging, so check scan needs to be done at least 4 hours after doing a biopsy, just to check if there is no pneumothorax, and if there is, quantification of pneumothorax. And pneumothorax increases if the lesion is located in subpleural location, small lesions, emphysematous changes, longer path of needle, and wider angle of incineration. So always we need to be more perpendicular as far as possible and traverse from non-irritated. So there are three types of pneumothorax which we generally see. One is a small pneumothorax, which can be managed conservatively. When there is a large pneumothorax, either need a small bore, that is a pigtail catheter insertion, so that the pneumothorax can be drained and patient do not go into compromise. And whenever there is a large pneumothorax with great amount of surgical emphysema, that is a time where large bore catheter or intercostal drainage tube needs to be inserted. And can we do biopsy post pneumothorax? Yes, we can. Post pneumothorax, many patients will have effusion which requires drainage, so they would ideally drain it, and then there would be some pneumothorax which would be happening, and then we can perform a biopsy. Or else we can even come out and do the aspiration while doing a biopsy. There is a chances that pulmonary hemorrhage can also occur, but these is self-limiting, and patient needs to lie on the ipsilateral position. And chances of hemothorax are pretty much, they are around 1%. And coming on to endobronchial ultrasound guided biopsies or FNAC for mediastinal nodes. So what are the indication? So one is for staging non-small cell lung cancer, for sampling of mediastinal nodes, for diagnosis if there is unexplained mediastinal lymphadenopathy, and as a research tool for tissue banking. So what is suspicious lymph nodes on EBUS is round, well-defined nodes with loss of fatty hilum, heterogeneous echotexture, and presence of necrosis, and more vessel into the nodal hilum. So advantage of EBUS is it's pretty much minimally invasive, real time, it's safe, wide lymph nodes can be targeted, and which decreases the unnecessary thoracotomies and complication. So limitation are, it is more operator dependent because it's ultrasound guided. EBUS cannot image a sample or subaortic or prevascular lymph node. The image quality is poor as compared to percutaneous biopsy, and it is an aerosol generating procedure. So I would just give you this is last example. So these are 4 clinical scenarios where the lymph node is located in various locations. So where 270 degrees it's surrounded by the vessels around it. So here it's either SVC and pulmonary trunk. Here it would be same on one side, it's azygous, so when we enter via bronchial bronchoscopy guided, it would be just behind it, and just we need to do FNAC or a biopsy from this area, and it is less complicated as compared to percutaneous approaches. So this is a lymph node which is located here in the prevascular space in paratracheal region, and then FNAC can be done via EBUS guided. So coming on to the take home message, these are minimally invasive procedures which are indispensable for diagnosing thoracic lesion. It is very safe and effective with good accuracy, and it is a daycare procedure, can be trained by any intervention radiologist. Thank you, and I am happy to have